Hello, my dearest viewers. Welcome to AETCM Rapid 50 session. This is Dr. Sabah Ali, and I'm the resident of ER. And in this video, we'll be talking about hypo and hyperkalemia. So we will begin. So let's begin with our first topic, that's hypokalemia. Now, before I begin, I would like to let you all know that my presentations have been strictly restricted to our standard textbooks, Tintillani and Rosen, which is why it will be easy for you all to read and remember now that our exams are nearing. So this comprises of major keywords, and I will try and simplify and make it as easy as possible. Now, starting with hypokalemia, as we all know that the normal range of potassium levels in the body is 3.5 to 5 milliequivalents per liter. Now, when this potassium level falls below the normal lower limit, that's less than 3.5 milliequivalents per liter, we call it as hypokalemia. Now, there are many causes for hypokalemia, but if I have to broadly classify, I would say that they fall into three major headings. One, when there is insufficient dietary intake. Second, when there is increased loss of potassium, and then there's like intracellular shifts of potassium. Now, potassium is extremely essential for a cell to function, for action potential. Now, what happens is potassium levels, when they fall below the normal range, the resting potential becomes more and more and more electronegative, which will enhance the depolarization, that is the deactivated state of a cell, and because of which repolarization will not happen. When repolarization doesn't happen, that will delay the conduction, which will ultimately lead to muscle paralysis. Now, why I've mentioned atrial paralysis in specific is because potassium levels have profound effect on cardiac muscles. So when the levels go down, cardiac muscles are affected more. So this will lead to the muscle paralysis, specifically the atrial paralysis, which will lead to bradycardia and cardiac arrhythmias, as we will see. Now, when we talk about the causes of hypokalemia, we'll put them under three main headings, like I mentioned earlier. One would be when there is insufficient dietary intake. Second, when there will be increased losses. And third, it's because of the intracellular shift. Now, when we talk about the transcellular shifts, the causes could be alkalosis, increased plasma insulin, and beta-adrenergic agonists. Now, to know that insulin and beta-agonists role in maintaining potassium levels in the body is extremely crucial because they cause shift of the potassium. Now, let's just say if the patient ends up with hyperkalemia. If we provide the patient with insulin and beta agonists, it will cause again shift of potassium levels, and potassium levels go down. But if in the body insulin is increased, or if beta adrenergic agonist is administered to the patient, it will cause shift of the potassium leading to hypokalemia. Now, when we talk about the decreased intake, like the food intake, fasting, alcoholism, eating disorders could be the examples of it. Alcoholics anyway are malnourished because they are too dependent on alcohol, and they don't have proper nutrition, because of which even the potassium levels in their body go down because of decreased food intake. And we talk about the increased losses. Loss can be due to anything. It can be because of GI loss, or it can be a renal loss, or it can be due to sweat. When we talk about GI loss, this vomiting, diarrhea, or if it's not absorbed well, malabsorption, or when a patient is put on RT, like nasogastric tube and nasogastric suction. So when you're suctioning out all the stomach contents, again, that's a GI loss. Now, when we talk about the renal loss, it can be because of diuretics, hyperaldosteronism, renal tubular acidosis. Drugs, it can be many drugs like aminoglycosides, penicillins, amphotericin B, levodopa, lithium, steroids. Any of these drugs can cause increased loss of potassium levels from the body. Diuretics here, I mean the loop diuretics and the thiazides, not the potassium sparing diuretic like spironolactone. Now, when you talk about, like sweat loss, all the activities that cause, increased sweating, heavy exercise, or when you set out in the sun for a long time, the heat stroke, or in cases of fever, when patient starts to sweat, you have loss of potassium via sweat. And other causes can be because of hypomagnesia or acute leukemias and lymphomas and hypothermia. Magnesium and potassium are very closely related, which is why whenever there is hypokalemia, hypomagnesemia also will be seen in such patients. Now, when we talk about the clinical features of hypokalemia, it becomes extremely important for us to understand that potassium is essential for action potential of a cell. Now, all the abnormalities that will show up when the potassium level goes down below the normal level is because of abnormalities in the membrane polarization of a cell. And this is extremely, or rather particularly dangerous in cardiac muscles. Not that other muscles won't be affected, but the effect is more profound and excitable myocardium. Now, usually all the symptoms will start to show up when potassium level goes below 2.5 milliequivalents per liter, but symptoms can appear sooner when there is rapid fall in the potassium level, either because of increased potassium loss or because of increased transcellular shift. Whenever there is a rapid drop in potassium levels, symptoms will show up earlier, or otherwise potassium level when it goes below 2.5 milliequivalents per liter, symptoms will start to appear. Now, when we talk about the signs and symptoms, again, each organ system of the body gets affected. When we talk about cardiovascular system, which is majorly affected, it will lead to hypertension, orthostatic hypotension, potentiation of digitalis toxicity, and dysarrhythmias. Now, digitalis, when a patient is taking digitalis, they'll have to be extremely cautious because when the potassium level goes below the normal range, the action of digitalis increases, which is why you'll have potentially the toxicity levels increase. It will enhance the digitalis levels in the body. Now, when we talk about the neuromuscular system, it will lead to weakness, fatigue, because there is delayed conduction, hyporeflexia, cramps, paresthesias, and ultimately leading to paralysis. Now, GI symptoms comprises of nausea, vomiting, abdominal distension, majorly because of intestinal ileus. That is, again, the intestinal muscles. The action of it is hampered. Now, renal system wise, you'll have increased ammonia production, metabolic alkalemia will be seen, and nephrogenic diabetes insipidus is also a cause that, or rather a sign and symptom of hypokalemia. And endocrine wise, there will be glucose intolerance. So when a patient presents to us with multiple episodes of vomiting, persistent diarrhea, or just generalized weakness, paresthesias, malaise, fatigue, then electrolyte imbalance has to be the first thing that needs to be ruled out. And special attention has to be given to the potassium levels as they have a profound effect on excitable myocardium. Now, as to why the patient landed with hypokalemia, the etiology of which can be found out through additional testing. Now, one of the first investigations that we do is an ECG, and we look into the features of hypokalemia, that is prolonged QTC, prolonged PR, flattened T waves, peaking of P waves, and appearance of U waves. Now, we will eventually find out through the video that hyperkalemia has the exact opposite features on an ECG. And the other investigation that we do is the blood gas analysis when alkalosis is suspected. Now, if the cause of hypokalemia is not very apparent, either from history, because the patient is not really presented with all these features like vomiting or diarrhea or weakness, then spot urinary electrolytes can be taken before we start with potassium replacement. So this is an image of an ECG of a patient with hypokalemia. As we see that there is prolonged PR interval, there is prolonged QTC, there is flattening of T waves and presence of U waves. So this is an ECG of a patient with hypokalemia. Now, when we look into the etiology of hypokalemia as to why the patient ended up with it, and if it is not very apparent from the history, then we collect the urine sample to find out the potassium level in the urine before we start with potassium correction. Now, spot urinary potassium, if it is less than 10 milliequivalents per liter, then we can safely rule out renal loss as our etiology. Now, then it will point to the two other major headings, that is the decreased potassium intake and the transcellular shift. like, because of alkalosis and hypomagnesemia. The other etiology can be non-renal loss or losses uh, through sweat or GI, nasogastric suctioning. But if potassium levels are more than 20 milliequivalents per liter, it will majorly point towards the renal loss. Now, if hyponatremia coexists, then we will consider hyperaldosteronism or major GI or massive GI losses. Now, there is something else called as a transtubular potassium gradient, which is calculated by the product of urinary potassium levels with serum osmolarity, and we divide it with another product of urinary osmolarity and potassium levels in the serum. Normal values will be 8 to 9 milliequivalents per liter. Now, this gradient was again done to find out the etiology of potassium loss or low potassium levels. Now, any value that is lower than 5 milliequivalents per liter will suggest hyperaldosteronism, and if paralysis is present, values anything less than 3 milliequivalents per liter will suggest hypokalemic periodic paralysis. Now, once we have identified hypokalemia and diagnosed a patient with it and also found the etiology behind hypokalemia, then treatment is very simple. It is just replacement of potassium levels. And this should be done orally in stable patients with mild hypokalemia, that is potassium levels more than 3 milliequivalents per liter. And patients should be encouraged to have food which is rich in potassium levels, that is fruits, dry fruits, vegetables, and potassium supplements also have to be prescribed with abundant or adequate fluids. And what next? We just treat the underlying cause. Now, if the patient has landed up with severe hypokalemia, that is potassium levels to be less than 2.5 milliequivalents per liter, or if the patient is symptomatic with moderate hypokalemia, that is potassium levels ranging anything between 2.5 to 3 milliequivalents per liter, then IV replacement of potassium is what is recommended. We treat patients with cardiac arrhythmias, that is when we see ECG features of prolonged QTC, prolonged PER, peaked P waves or flattened T waves or U waves, then or when oral replacement is not tolerated in these patients, again we go with IV replacement. But when we are replacing the patient intravenously through, or rather when we're giving IV correction, then we monitor the patient's rhythm along with it, as it is essential because it will again disturb the cardiac rhythm. When we are correcting hypokalemia and replenishing the patient's potassium levels, there are certain principles that we need to keep in mind before correction. First would be the ECG monitoring. I cannot stress on this enough. And second, we use potassium chloride and we avoid administering potassium in glucose solution because it will again cause insulin levels to rise, which will again cause intra or transcellular shift. Third, potassium is irritating to the endothelium, so we need to adequately dilute the solution before administering to the patient, and otherwise it will cause pain and phlebitis. Now, infusion rates should never exceed more than 20 milliequivalents per liter. And in most cases, hypokalemic patients are also hypomagnesic, so we correct the magnesium levels in the body too if they are low, and it can be added to the infusion. So this is how we treat hypokalemia. So in a nutshell, we identify hypokalemia when the range of potassium levels falls less than 2.5 milliequivalents, less than 3.5 milliequivalents per liter. Then we find out the cause under three main headings of transcellular shift, of decreased food intake, or because of increased losses. Majorly it will be because of renal loss, and patient will present with symptoms of nausea, vomiting, generalized weakness, fatigue, and paresthesias. But if the cause of hypokalemia is not very apparent, we start with, or rather we collect the urine sample to check for the potassium levels in the urine, and if it is less than 10 milliequivalents per liter, we rule out the renal cause and look into the other causes like transcellular shifts, or because of non-renal loss, GI losses, or because of decreased food intake. But if the urinary potassium levels is more than 20 milliequivalents per liter, then renal loss will be the major etiology as to why the patient had hypokalemia. So once we identify, once we diagnose and find out the etiology behind hypokalemia, we treat the patient with potassium replacement. Now, in potassium replacement, we can replace it in two ways, one oral and IV. Oral, we go with those patients who have only mild hypokalemia and mostly asymptomatic. We ask the patient to eat food that is rich in potassium levels, and also we can prescribe potassium levels with potassium supplements with adequate fluids. And but if the patient has moderate hypokalemia or severe hypokalemia, and or rather if the patient is symptomatic, we go with IV replacement. We look into the features of ECG of hypokalemia, that is QTC prolongation, PR prolongation, P wave flattening, P waves peaking, and U waves. If ECG changes are there, or if the patient is symptomatic, IV correction. But the thing with IV correction is that potassium is very irritating to the endothelium, so we adequately dilute the solution, and we avoid in adding glucose solutions to it, because it will again increase insulin levels in the body, causing transcellular shift. And our infusion rate should never increase 20 milliequivalents per hour. And when we are correcting the patient through IV route, it is essential that we monitor the patient's cardiac rhythm through ECG. And hypokalemia and hypomagnesemia are pretty much correlated. So if at all you see hypokalemia, hypomagnesemia should be suspected and also should be added to the infusion. So this concludes hypokalemia. Moving on to the next topic, and that is hyperkalemia. Now, hyperkalemia is defined as potassium levels to be more than 5.5 milliequivalents per liter. It's the other end of the spectrum. And the most common cause of hyperkalemia is pseudo-hyperkalemia, which means to say that the potassium levels are falsely elevated, and it is due to release of intracellular potassium, which is caused by hemolysis. If the technique of blood withdrawing is wrong, then it will cause hemolysis, and which will lead to the release of intracellular potassium, and that will be detected as high potassium level. Now, clinical manifestations, just like hypokalemia, results from abnormalities in the membrane polarization. Now, just like hypokalemia, the most profound effect will be seen on cardiac muscles, myocardium. So when we talk about the pathophysiology of hyperkalemia, it is essential to understand that calcium and potassium, they function, or they have an antagonizing effect on the cardiac myocyte. So in hyperkalemia, the resting membrane potential of the myocardium becomes less and less electronegative, and it will cause the reduced activation of voltage-dependent sodium channel, which will ultimately cause result in slower and reduced amplitude of action potential. Whereas calcium, it works exactly in the opposite way of potassium. It antagonizes the effect of hyperkalemia, and it will act on the cell membrane. It will restore the membrane potential and excitability of the myocyte by raising the threshold potential of the cardiac muscle cell. So what calcium does is just stabilization of the membrane, and it antagonizes the effects that has been brought on the cardiac muscle cell by increased potassium levels in the body. The causes for hypokalemia are way too many, but the major cause is pseudo-hyperkalemia. It means to say that the potassium level is falsely elevated, and it is majorly because of improper technique of blood withdrawal, either because of tourniquet use. Whenever there is hemolysis, there is intracellular potassium gets released out, which will falsely elevate in that sample, showing a false reading. Now, if once we find out that the patient has hyperkalemia and pseudo-hyperkalemia is ruled out, there are other causes for potassium increase in the body, and that is majorly because of intra to extracellular potassium shift, either caused due to acidosis or heavy exercise, or because of beta blockade and insulin deficiency. Like we discussed earlier, beta agonist and insulin causes potassium to shift from extracellular component to intracellular component, causing hypokalemia. Now, when their action has been restricted or blocked, then it will cause intracellular to extracellular potassium shift. And when we talk about the digitalis intoxication, Hypokalemia causes potentiation, that is, it enhances digitalis toxicity. But digitalis intoxication causes hyperkalemia. Uh, then there will be increased potassium load, either because of too much of potassium supplements that the patient has been on, or because of transfusion of aged blood. Again, reason being hemolysis, potassium from the cells has been released out, or because of GI bleeding, cell destruction, wherever there is cell destruction, potassium levels from the cell, if it is being thrown out or released out, it will cause increased potassium levels, either because of rhabdomyolysis, wherein you'll have muscle injury or cell destruction, or because of extensive tissue necrosis, cell death, or cell has been broken, destroyed. Potassium levels gets thrown out into the system, causing potassium levels in the blood to elevate. Now, the second, or rather the third thing, is when there is decreased potassium excretion, when there is renal failure. And then there are drugs like potassium sparing diuretics. Mind you, just loop diuretics or thiazides causes hypokalemia, whereas potassium sparing diuretics like spironolactone causes potassium levels in the body to go up. NSAIDs, ACE inhibitors, ARBs, all the drugs that cause renal failure act, or rather contributes towards hyperkalemia. Other causes will be aldosterone deficiency. Hypoaldosteronism is a cause for hyperkalemia, whereas hyperaldosteronism causes hypokalemia. To again stress, potassium level, normal potassium levels are extremely important for normal functioning of a cardiac myocyte. Hypokalemia or hyperkalemia will cause rhythm disturbances leading to cardiac arrest. Now, whenever there is hyperkalemia, there is cardiac dysrhythmias like ventricular fibrillation, SA node, AV node block, until leading to complete heart block and ultimately causing asystole. But what I would like to mention here is, in hyperkalemic cardiac arrest, heart stops in diastole, whereas hypercalcemic cardiac arrest, heart stops in systole. Now, other symptoms will be neuromuscular dysfunction, weakness, paresthesias, areflexias, again causing paralysis, along with other GI effects of nausea, vomiting, and diarrhea. Hypokalemia and hyperkalemia, symptom-wise, are very closely related. In hypokalemia also you see a periodic paralysis. Hyperkalemia also has a periodic paralysis. Both will cause weakness, paresthesias, areflexias. Both will have cardiac dysrhythmias leading to bradycardia, asystole, and death. Whenever hyperkalemia is suspected in patients, ECG becomes the primary investigation that needs to be done at the earliest in order to rule out cardiac dysrhythmias. We look for ECG changes which pretty much corresponds to the potassium levels in the body. Like for example, if the potassium is ranging anywhere between 6.5 to 7.5 milliequivalents per liter, ECG shows prolonged PR, shortened QT, tall peaked T waves. Tall peaked T waves becomes the one of the first change that we see on ECG, and all these changes is because of repolarization abnormalities. Now, when the potassium level goes beyond 7.5 up until 8, P waves slowly start to flatten out and there will be QRS widening, and this is because of atrial paralysis. Whereas if if potassium levels goes beyond 8, then it is severe hypokalemia, and therein we'll see the QRS widening will have like degradation and it will become a sinusoidal pattern. So chronic or slowly developing hypokalemia, these changes may not be very evident until severe potassium levels are reached, like in cases of CKD patients. But whenever there is acute hyperkalemia, all these changes will be very evident on the ECG. Now here is an image of an ECG of a patient with hyperkalemia. As we can see, these are the tall peaked T waves which will be very evident on the precordial leads, and it is one of the first changes that will be seen on the ECG when the potassium levels is like starting to rise. And then there will be PR prolongation with QTC shortening, and if at all it becomes more and more If at all the potassium levels increases more and more in the body, then QRS widening will occur. Eventually, the P waves will flatten out because of atrial paralysis, and then QRS becomes too wide until a sinusoidal pattern is achieved. Early identification of hyperkalemia and treatment is extremely crucial as it is a life-threatening emergency. It can lead to cardiac arrest. But what is more important is the fact that it is a reversible cause of cardiac arrest. So if a patient has ended with cardiac arrest and hyperkalemia is the cause, and if it is detected early and treated, the chances of revival of the patient is extremely high too. So if ECG changes are present, treatment should begin at the earliest. A symptomatic patient with just small elevated potassium level of say 5 to 6 milliequivalents per liter mostly requires identification, and we treat the underlying cause. It can be because of renal failure or because of rhabdomyolysis or any transcellular shift. Whatever the cause is, it needs to be addressed and treated. Now, if the potassium level in the urine is elevated to more than 20 milliequivalents per liter, it will point towards an extrarenal cause. It can be a shift of potassium, or it can be increased intake of potassium through supplements. But if a low urine potassium output, like less than 10 milliequivalents per liter, is there, then it will point towards oligouric kidney failure, or because of drug effect like ACE inhibitors, ARBs, NSAIDs, which will cause renal failure, leading to hyperkalemia. So they are quite opposite actually, hypokalemia and hyperkalemia. So in a hyperkalemic setting, if the urine potassium is less than 10 milliequivalents per liter, it will point towards renal failure. And if it is more than 20 milliequivalents per liter, we will think of extrarenal causes. Now, in converse to this, in hypokalemic settings, if it is more than 20 milliequivalents per liter, it points towards the renal loss, whereas less than 10 milliequivalents per liter, we think of the non-renal causes like transcellular shifts or decreased potassium intake, or because of GI losses. Now, moving on to the treatment aspect, all the medications will, or the treatment is broadly can be studied under three main headings. One, those drugs that stabilize the membrane. The second set of drugs will cause the intracellular shift of potassium. From the extracellular component, potassium gets shifted back to the intracellular component. And then comes those drugs that will cause excretion of potassium from the body. Now, these three things, or these three main headings, under those treatment aspect will be discussed. Now, blood gas is essential if acidosis is present, because treatment of acidosis will naturally correct the acid-base imbalance, or it will correct the potassium levels in the body. But if pH is normal or alkaline, then therapeutic measures have to be taken to promote this shift, but it will be less effective, and the treatment will be aimed more towards excretion. So why do we take an ABG? It is to see if there is acidosis or not. If at all there is acidosis, then we treat the underlying cause of the acid-base imbalance and potassium levels become okay. But if at all the pH is normal or alkaline, then the shift mechanism will become ineffective, and we'll have to focus more on removing the potassium from the body through the renal system. So emergency therapy of hyperkalemia is all stated in this one tabular column, but what I want us to focus is that even if it is in this tabular column, the mechanism will be studied under three major headings as discussed. The first two drugs, that is calcium chloride and gluconate, falls under the category of membrane stabilizers. They have nothing to do with the treatment of hyperkalemia as such when we talk about potassium shift or excretion. They have no role, calcium has no role in potassium excretion or in shift of potassium. All potassium, but it is extremely important in treatment of hyperkalemia. In fact, it is the first thing that we do when we see hyperkalemia is to protect the heart. So they are the cardiac protectors. they will raise the threshold potential and it will agonize the ill effect of increased potassium on the cardiac myocyte. So the dose is pretty much the same for both these drugs, that is 5 to 10 ml IV, but it is given as a slow IV over a span of about 10 minutes. Onset of action will be about 1 to 3 minutes and duration will last for up to half an hour to 1 hour. Now, the second component that we will be discussing will be those shifters, the drugs that will shift potassium from extracellular component back into the intracellular component, and those will be insulin and beta agonists, and also put sodium bicarbonate. These will cause the shift. So insulin is generally given as a GI bolus dose, wherein we take, here in our hospital, we take 25% dextrose and 100 ml 25% dextrose, and we add 8 units of actrapid. So this is the GI bolus that we use, and because glucose is added in there to counteract the ill effects of insulin. So 5 to 10 units of regular insulin is given along with 25 grams of glucose. But let's just say if the patient has increased glucose levels like 400 plus, 300 plus, then we do not give a combination. In that case, we only give insulin dose, and this will cause a shift of potassium into the cell. Onset of action is quite rapid, within half an hour, and will last for about 4 to 6 hours. So other than this, we can also give nebulization doses of salbutamol or albuterol, but they are given in 10 to 20 milligrams. The general nebulization that we give for respiratory issues is 5 to 10, 2.5 to 5 milligram, but to correct hyperkalemia, we go with 10 to 20 milligrams and 4 ml of normal saline, almost double the dose, and we give this nebulization over 10 minutes. This is a very quick onset of action of about only 15 to 30 minutes, and the effect will last for up to 2 to 4 hours. Sodium bicarbonate, very similarly, we give in the dosage of 50 to 150 milliequivalents IV. Action will start within 5 to 10 minutes and it will last for 1 to 2 hours. So the next three things are the shifters, the salbutamol, rather the beta agonists, insulin and sodium bicarbonate. These are the shifters. The last part would be the excretors. They will push or excrete the potassium out of the body. That is diuretics. Diuretics, not the potassium sparing one, the thiazides and the loop diuretics. That is loop diuretics, meaning the furosemide. That is given in the dosage of 40 to 80 milligrams IV, and it will cause excretion of potassium via kidneys. The other one is not popularly used, that's the sodium polystyrene sulfonate. And the last one, if nothing works, the last resort is hemodialysis. If at all the patient is in severe metabolic acidosis, or patient is in has profound ECG changes, then in order to prevent cardiac arrest, hemodialysis is also done as a major treatment, or major treatment as major treatment. So those are the calcium drugs are membrane stabilizers, sodium bicarbonate, salbutamol are the beta agonists, and the insulins are the shifters. Diuretics and hemodialysis falls under the excretor category. But let's just say if a patient is in cardiac arrest, then we give calcium chloride and we push sodium bicarbonate. And if the patient has revived and potassium levels are persistently high, hemodialysis will be your go-to therapy. But if at all patient is not in cardiac arrest, we give a combination of calcium chloride and GI bolus along with nebulizations for insulin. So this is how hyperkalemia is treated. So whenever we are treating hyperkalemia, there are a few general principles that we keep in mind. One is continuous ECG monitoring, and that will have two advantages. One, it will confirm the effects of a therapy, and second, it will reduce the frequency of rechecking potassium. That is, whenever potassium levels are coming down because of our therapy, ECG changes will go back to normalcy, and we will be able to see the effects of our therapy on the ECG screen, like monitor, immediately. And the other principles requires immediate cessation of further administration of potassium. We will reduce the dietary intake of potassium and also stop all the drugs that will impair renal function, and we will promote renal excretion of potassium out of the body, either by giving more fluids or by giving diuretics. And like we discussed previously, sodium bicarbonate can also be used to shift the potassium back into the cells. But the disadvantage of sodium is that when it breaks down, it will break down into carbon dioxide, and that will again add to the acidosis of the patient. So when the sodium bicarbonate is generally the go-to drug when the patient is in cardiac arrest and not otherwise. So correction of hyperkalemia is always done on an emergency basis. We first protect the heart, we shift the potassium, or we kick the potassium out of the cells through diuretics or hemodialysis. Now, when ECG detection in hyperkalemia is extremely important, which is why I thought I'm gonna compare a normal ECG with hypokalemia and hyperkalemic changes. So normal ECG, as we see, there's a P wave, there's a beautiful QRS complex, there's a T wave and a U wave. Now hypokalemia and hyperkalemia have pretty much the opposite effects. In hypokalemia, like we discussed, there will be prolonged PR interval, there will be presence of ST depressions, flattened T waves and peaked P waves with a prominent U wave. Now in hyperkalemia, you will have flat P wave, tall T waves with QRS widening and prolonged PR interval. So this would be the ECG changes that we see in hypokalemia and hyperkalemia. As we can see, this is an ECG of severe hyperkalemia. I just wanted to show the sinusoidal wave, and this is a precardiac arrest rhythm which will call for emergent hemodialysis. So treatment of hyperkalemia is extremely crucial as it will cause ventricular fibrillation, asystole, and it is a reversible cause for cardiac arrest. So to quickly conclude, hyperkalemia in a nutshell, we discuss hyperkalemia as that state wherein the potassium level is more than 5.5 milliequivalents per liter in the body, and it is majorly because of increase pseudo-hypokalemia, that is improper technique of blood withdrawal, wherein there is release of intracellular potassium, either because of hemolysis or because of tourniquet usage. And then there is, when we talk about the true hyperkalemic causes, it will be because of the shift from the intracellular component into the extracellular component, either because of insulin deficiency or because of beta blockade, or the other cause would be the renal failure cause, wherein the kidneys are not functioning well and potassium levels just keep adding on into the system. So early identification of this state and etiology and to find the cause of hyperkalemia is extremely important, as it is a reversible cause of cardiac arrest and will have a profound effect on the myocardium. Major disturbances is because of abnormalities of the membrane polarization. So when we treat hyperkalemia, it is again divided into three major headings. One are the protectors, membrane stabilizers, calcium chloride and calcium gluconate. Second component would be the shifters like potassium, like sodium bicarbonate, insulin, and beta agonists like salbutamol, albuterol, and the third component would be the excretors like your diuretics and hemodialysis. So under protectors, shifters, and excretors, we treat hyperkalemia. So this concludes my topics, hypokalemia and hyperkalemia. Thank you.